Yeah, let's dive right in. Today, we're going to be chatting about the science driving the hopefully smarter blood tests that we can use to screen for prostate cancer. And I think this is a big challenge for us because, as we know, over the past several decades, PSA screening really did change the game. We were able to screen men more effectively. We were able to save countless lives and catch prostate cancers earlier before they spread aggressively or metastasized. But there's this unique conundrum in that we sometimes catch clinically insignificant prostate cancer, and at the same time, PSA still roughly misses about 1 in 4 aggressive tumors. What are your thoughts on this challenge we face?
Yeah, I think it highlights the limitations of PSA. PSA is prostate specific. It's not cancer specific. And an elevated PSA, I mean, we learned this, the first day of residency, can come from benign conditions like BPH or prostatitis. The other thing that we know pretty well is that some aggressive prostate cancers do not produce significant amounts of PSA, or the PSA produced does not reach the bloodstream in detectable quantities. Thus, the patient may have a tumor and may not have an elevated PSA above the biopsy threshold, leading to false negatives. The other issue is that the thresholds we have, whether your institution uses 3 or 4, are essentially compromises between sensitivity and specificity. Lowering the threshold increases the detection or sensitivity, but it will also increase the false positives and overdiagnosis of indolent disease, while higher thresholds will miss more aggressive cancers, but, kind of lower that specificity. And then the other thing that, we all know very well is that there's limitations to biopsying. So our endpoint is not perfect. So we know that biopsying, even infusion biopsy or standard transrectal biopsies, will miss a lot of aggressive tumors, especially if it's a small one or if it's like a high anterior tumor. So there's a lot of limitations to PSA. PSA is a good test, and what I say a lot in the clinic, it's a good test, but it's far from perfect.
Yeah, it's tough because, I think that's the challenge for patients is they get sent to us for an elevated PSA. They come in thinking it could be cancer, and it's just a signal that there's something going on with the prostate, whether it's enlarged, whether it's cancer. So hard for us to know. And, an area that we saw that showed some promise and utility was refinement like percent free PSA or PSA density, which I do think are useful. And I'm curious, do you find these useful? How does that discussion go in the clinic?
Yeah, I mean, free PSA and PSA density added incremental gains, but they still miss a lot of aggressive cancers, and they kind of really didn't live up to the hype, and they lead to overdiagnosis and overtreatment. Pre-PSA, and PSA density are good. They reduce unnecessary biopsies, improve the diagnostic performance, but it's really still suboptimal. If you look at free PSA, which, I think there's a lot of residents that listen to the BackTable. It measures, I'll just explain what it is. It just measures the proportion of unbound free PSA to total PSA in the blood. A lower free PSA is better. So it's opposite or inverse to PSA. It's good. It's better. I'm not going to say it's terrible, but it still has a lot of limitations. And I think there's been a lot of studies over the last decade or even longer that's critically evaluated free PSA, and we see some inconsistent risk stratification, missed cancers, unnecessary biopsies. And there was this great meta-analysis that, in early 2000 that looked at almost 20,000 patients and used this free PSA cutoff of about 20%, which is kind of a little higher than what we use in our institution. But when you look at how it performed, it was 92% sensitive, which obviously is good, but the specificity still was kind of weak at 23%. The area under the curve, which is a critical number to measure all these, markers, was only 0.7. So it's good, it's better, but again, it misses and produces a lot of false positives. And in that gray zone or that tricky area of 4 to 10 PSA testing, free PSA is okay. It only really works when you get those super high or super low numbers.
Yeah, that's right. We've seen, especially in the past decade or so, a lot of movement to try to get smarter PSA testing, advances in certain fields like genomics or proteomics. So tell me a little bit about where the trend has brought us today.
Yeah, it's a great question. It's exciting, and this is what gets me excited for me, and for our patients. It's really what we've seen in the last 10, 20 years is that we've moved away from concentration-based biology, like what's your level of PSA, what's your level of free PSA, and moved into measures in molecular biology. So that there's been significant advances in molecular biology, so we can have these like kind of multi-marker strategies that integrate proteomic, genomic, and transcriptomic data to improve specificity and reduce overdiagnosis and truly guide personalized management. So it's, again, not how, trying to look at the biology of these cancers and using these advanced molecular techniques to really give us better guides or better insight to whether the patient has significant cancer or is low risk or no cancer.